this afternoon. And thank you, Sobia, for pressing recording. I'd really like to welcome Jonathan back, who's going to deliver our Safety Net seminar today on quality versus safety in healthcare, which Jonathan is framing as a national debate for patient care. So really looking forward to this exciting position that Jonathan is taking. Just a few words about Jonathan, who joined the Health Services Safety Investigations Body in the UK as an analyst. But Jonathan's previous background was actually in academic positions at the University College London and King's College London. His PhD is from Loughborough University, where he is now a visiting research fellow in safety science. And his work, specifically at HSSIB, focuses on improving the management of safety and understanding inequalities. We're really looking forward to hearing from you today, Jonathan. I think you're going to talk for around about 45 minutes, leaving us with some time to ask you questions at the end. If anybody does have any questions, please feel free to pop them in the chat as Jonathan's talking, and I'll pick them up, or write them down in front of you, and I'll ask for questions at the end of Jonathan's talk. So thank you very much, Jonathan, and over to you.
Perfect. Thank you very much, Rebecca. So I'm Jonathan Back. I'm from HSSIB. Currently an analyst, but moving into the investigations team in September. And today I wanted to talk about quality versus safety as a concept. This presentation, we published a paper which was presented at the Chartered Institute of Ergonomics and Human Factors this year. We also had a workshop session as well, which was useful to get the viewpoints of people across industries. And I think part of my background is that even though I've been involved in healthcare for a while, I also have experience of working in other industries like control rooms in nuclear power and also in transport. So it's always interesting, and I know there's often been a challenge in terms of importing ideas from aviation, for example, into healthcare, and that's not lift and shift, of course. But it's interesting to come in with that perspective, I think, of different industries and how they manage things. And I think that's quite central to the idea of when we define terms like quality and when we define terms like safety, what do we actually mean? Because in other industries, we've got ISO standards, we have definitions which are more widely understood, I think. So it's interesting to see how healthcare addresses some of these concepts. So I wanted to start just by reflecting on something that was published yesterday. So yesterday, the National Quality Board published via NHS England the quality strategy for NHS funded care in England. So that was published yesterday. It's been in draft for a number of months. And what it does is it follows the Penny Dash review into the patient safety landscape. So it really captures and it really outlines an operational framework for how the NHS, and this is specific to NHS funded care, how the NHS manages quality. Here, and this is really the central bit about what I'm going to be talking about, is the idea here, and it's included, this idea is perpetuated within this quality strategy, and it's also exists in Darzy's work, for example, when he did that review of the NHS a couple of years ago. And it also appears in things like the long-term plan, the 10-year plan. The idea that high quality care is in fact comprises of three core domains, one of those domains being safety. And that's the idea that I hope to challenge today, that safety is in fact not a domain of high quality care. And that's the argument that I'll be presenting today. And of course, that is an argument based on work we've done at HSSIB, but also reflect some of the things that we've heard from stakeholders as well that we work closely with in the system. So the idea here is that we have three core domains that make up high quality care, and that's safety, effectiveness, and experience. And of course, we agree that all three must improve together, and that focusing on just one element is something that we can discuss, and what that actually means, the idea of focusing on effectiveness instead of safety, the concept around that and the trade-offs around that is something that I can talk about. So here's, like I've mentioned, so in July 2025, there was a review of patient safety, and this review concluded that there's been a shift towards safety over the last 10 years. And in fact, that shift hasn't resulted in significant improvements. That's what was stated by the report. And that shift was at the expense, to a large extent, of other areas of quality of care. That was the claim made in the report. There was a call to action needed to address gaps in functions, improvement in innovation and quality of care. And of course, the idea of linking things with safety with continuous improvement is something that many implementation scientists have worked on over the years, and something that is central. And of course, that can be improved, and there's no doubt that improvements could be made in that area. So one of the recommendations was the idea around revitalizing the National Quality Board. So this National Quality Board sits theoretically above the NHS and is made up of different stakeholders. So NHS England, soon to be just the Department of Health and Social Care, but also has representatives from other organisations such as the CQC and other stakeholder national bodies, including arm's length bodies. So the idea is that the NQB itself should be the role of the NQB, and this is specified in the strategy that was launched yesterday, that was published yesterday, is the idea that safety needs to be balanced across all dimensions of quality, and all activities should require that balancing. And the principles behind it is the idea that we have a finite resource, and that, of course, that's true. And healthcare value involves seeking to maximise the outputs per pound spent in the NHS. So that need to balance outcomes and costs as we go forward. So that was the main recommendation from that report. There was a response to that report from academics and also from ministers who have recently been involved in debating the new bill, for example, going through Parliament at the moment, the new healthcare bill. And these are three that we've picked out here to highlight. So Woodward is an academic who you might know, suggests that the report itself was edited by people who don't understand patient safety, or don't understand what safety is, which is quite a fundamental problem if you're coming up with a strategy for quality and safety. There's also comments around Carl McRae, who is well-known academic based in Nottingham, talking about agreeing that there needs to be change, there needs to be coordination across the system, but at the same time ensuring that any kind of improvements don't erode any safety activities that are ongoing and are quite fragile. And we've seen significant changes such as the implementation of PSERF from an investigation perspective, and educational offerings for patient safety specialists, for example, which have made a very significant impact onto the NHS and has increased awareness of patient safety amongst people who are practitioners working and managing with such skill and expertise, in fact, within the healthcare system. And ultimately, they are the people that all these strategies should make sense. You know, it should impact on them, and it should help them do their day job. And Carl McRae also reflected on that the approach taken, the idea that you can manage safety risks in the way that the NHS conceptualize safety risks wouldn't happen in any other safety critical sector in the same sort of way. There's also been comment from senior ministers and MPs, House of Lords, around that the Dash review did highlight many problems in the management of safety systems, and there are coordination issues. But then there's this misunderstanding of what safety is and how to manage safety, and that's something that's currently being debated across Parliament at the moment, and the reason why it's being debated is things like, for example, and talking from a HSSIB perspective, the proposal is that HSSIB, who are an independent investigator of patient safety concerns, will be merged into the CQC, who's the regulator. So that wouldn't happen in any other industry. You don't have the air accident investigation branch being part of the Civil Aviation Authority. And the reason why you don't have that is because the recommendations are often made to the Civil Aviation Authority. So where's the independence if you're making recommendations to the same body that hosts you? So that's one of the arguments. There's also other arguments around autonomy as well. For example, deciding at the moment, HSSIB can decide what we investigate. We have a criteria that we use to decide what we investigate. In the future, that's likely to be directed by the National Quality Board. So again, that independence potentially has been compromised in comparison to other approaches within different safety sectors. So here's the in terms of the argument with quality and safety, this is the diagram that's often used. It's from the World Health Organization, and it's been adopted. You can see it in many publications from NHS England. And the idea is that quality is central and has different domains. And these are the different domains as specified by the World Health Organization. The quality strategy itself just picks safety, effectiveness, and user experience. So the three hexagons on the right-hand side with quality in the middle, encompassing those three. Of course, accessibility, equity, and efficiency are also talked about, but they don't actually feature in the quality strategy in the same way as effectiveness and user experience does, for example. So here, it's back to basics, and I think that's important, and we think that's important, because what's happened is that concepts like patient safety are understood in different ways. And when you hear people talk about patient safety, we've heard recently, even in at the parliamentary groups where bills are discussed, and for example, the patient safety, it's been suggested that patient safety is about small things. It's about people not being able to use bits of equipment. It's about equipment not being designed properly. And it's about targets such as infection control and pressure ulcers being met. that conceptualization of patient safety is problematic if you have a systems-based understanding of what patient safety is, because we know that safety isn't something that the system has as such. It's the activities and processes that we use to manage risks and issues on a day-to-day basis. That's what safety is. In terms of quality in healthcare, quality means something very different in other safety critical industries. Quality is about a published standards of particular activities, and it's the measurement of performance against those standards, which isn't patient safety, because patient safety is dynamic and emergent, and doesn't necessarily have that level of quality assurance. So, for example, it's not about the ensuring that a widget meets certain measurements when produced. For something to be safe, it has to be adaptive, which is very different to a production line, for example, which much of quality comes from. Of course, safety and quality interrelate as concepts, which we can discuss further. And this idea of balancing is interesting, and I'll provide some examples from our own investigations where we've seen trade-offs between the dimensions of safety and quality. And of course, we can also reflect on what next. What does this mean now? We've got a quality strategy which doesn't encompass safety in the way that some would expect. What do we do now? So those are the questions, and I think what is interesting, I mean, here with the World Health Organization, we do have a definition of what safety is, and that's the avoidance, prevention, and of adverse outcomes or injuries stemming from the process of healthcare, and also the absence of preventable harm to a patient. So this is from 2010. I think one argument is this this definition doesn't capture the day-to-day safety management that people are doing on the ground. It doesn't capture things like the deep understanding of patient pathways and their requirements, and capturing needs of the system. It's more about here this idea that you start from the adverse outcome and you work backwards, and you think about the process a bit, and you think about how to make these things more preventable. But of course, that is quite a limited view of safety when you consider things like the need for adaptation. So interestingly, there are in the quality strategy, which of course you can look at, there are some definitions of what's meant by effectiveness and user experience. These definitions have been developed by the authors of the strategy work. They're not based on agreed international standards. They have been generated for the purpose of the report. And from a safety perspective, and from a kind of someone who's aware of how safety works in other industries, the idea that you would have the essential concepts but not have agreed definitions of what they mean, it could be considered problematic. So these are some of the things that many safety professionals working in the NHS, whether it's part of their role or whether it's an interest, and many of the academics who work in safety know that the complexities of the healthcare system. We know that there's trade-offs. There's ensuring that change happens, not just through mechanisms, but ensuring the culture is correct for that change to occur. The need for that variability and adaptability. Of course, the term unwarranted variability is used quite a lot by people, and of course that's required if some regions aren't catering to the needs of patients, or some hospitals have gaps in their service. But actually, the idea that variability and adaptability is needed day to day to manage safety, to ensure that patients are kept safe, is something that doesn't always translate. the idea that these all of these domains interact in a way that perhaps isn't fully understood, and of course, and that maybe no one can understand. So if you're trying to pull them apart without that understanding, some of the nuances of what safety is and how to manage it might be lost. So here it's some of this central question around what would it mean to balance dimensions of quality and safety, and this is something that we can talk to. We can look at some of the safety science theory that has been around for a while now. So this is Rasmussen's model, the idea that it's a capacity model. So you have in the center you can do work safely, and you can make decisions which mean that you can keep patients safe or people safe, or you can continue the functioning of the organization within some sort of accepted parameters. But the idea is that you have pressures such as workload, you have economic pressures, which all make that space for making decisions and keeping people safe have a threat, and essentially that central bit moves around and eventually it crosses a boundary. So this is really the idea that all these things like the economics, the workload, the types of pathways that we have can't be considered in isolation of each other. So I think the argument here and the argument we presented in this paper is that safety shouldn't be a domain of quality, and in fact should be more of a foundational concept. Because safety, as we've seen in many of our investigations, underpin many of these aspects of quality. So we have examples of where safety it underpins equity, efficiency, effectiveness, user experience. So the idea that it isn't central and in some way things can be optimized is interesting conceptually. And I think some of the examples that I'm going to give on the next couple of slides will help here. So what we did was we internally within HSSIB, we ran some focus group with our investigators and our analysts, and we discussed the concepts of quality and safety and how both we understood them as an organization, but also how they were understood widely across the healthcare landscape. And this is something that we discuss with stakeholders a lot. So there was really three themes that came out of these discussions, and that the main one is that safety and quality are oversimplified in healthcare. They're not clearly defined or understood. There's oversimplification. And even though the title of our paper was Quality versus Safety, it was a bit tongue-in-cheek because we kind of reject the idea that is actually a thing. We would suggest that safety is safety that underpins quality. And of course, from a systems perspective, from a complexity science perspective, we think that the idea that safety is just a dimension is problematic. So safety as a foundation of quality was another theme that came out. And we would argue that, again, that it's the foundation that quality is built, because high quality care cannot be built on harm. And in many other industries, we have concepts like ALARP, as low as reasonably practicable, which means that there is an inherent risk with processes and systems, and there is a risk that has to be accepted, but there is also a standard where we know that some things are unacceptable, and the idea is to define that standard and to ensure that that care is not below that standard. So then that leads to the idea that once you have a safe system, then you can build the quality aspects onto it, but you need those bridges before you do that. So there's quite an idea. There was also concerns expressed by the idea that if you seek a balance between the different domains, then that in fact might degrade safety, and the idea that safety promotes these trade-offs, vying for the same limited resources, is something that we see quite a lot, and that's not just from a national perspective, but you see that on the coalface, on wards all the time, people wanting resources, and the idea that things are being traded off is interesting, and some of the examples here I think might be useful. So before getting on to the examples, just some of the work that was done for this paper. We've HSSIB, we used to be called HSIB. We looked at 118 reports. 43 of those reports described what we would call a trade-off, and I'll give some examples. And some of these trade-offs did relate to the negative impact on patient safety because of the prioritizations of another dimension of quality. Interesting that prioritization was often around performance targets rather than actually trying to improve accessibility, for example, but a performance target associated with a dimension of quality. And interestingly, we find that these trade-offs happen at local, regional, national levels of the healthcare system, which you would expect as a part of a complex system, that these trade-offs are occurring all the time throughout the system. So onto some concrete examples that might be interesting for people. The first dimension we looked at safety and efficiency. And we see this. So we see that when doing risk assessments, when staff are doing risk assessments, there's an efficiency thoroughness trade-off. And this is the reality of working in an environment where there's competing demands. So the idea that work as imagined is the idea is that you would do these risk assessments, they would identify the need for preventative medication, in this case, to stop blood clot. But the reality is that because of all these competing demands and distractions, then you have this balance between risk and safety. So you can't trade off this thoroughness of risk assessments always to ensure that efficiency is improved. So it's that balance. There is a balance, but for us, it's more about the tools and the effectiveness of those tools that are being used and whether they add value to the work. And from a human factors perspective, of course, that's important to actually understand how tools are being used and whether they're actually useful and sensitive tools to be using. So the existence of risk assessments alone isn't sufficient. One of the aspects that we've also looked at is patient experience. So currently, which is quite popular at the moment, the idea of introducing online consultation tools into general practice. And of course, many patients report that this is convenient for them, and it offers them access to care that maybe they wouldn't have before. But what we've seen from our investigations is that some of these online tools being used means that the task of healthcare delivery itself becomes more complex, and in fact means that things are missed. And because of that, ultimately, even though if you do a survey, you might say, "Oh, patient experience has improved." In fact, the task of delivering healthcare safely and addressing the needs of users means that ultimately there's problems in the way that the technology is sometimes designed, conceptualized, and used. So it's not ultimately, it doesn't address the needs of users. Safety and accessibility is another dimension that we've looked at as part of this analysis. And this is often, like I mentioned before, this focus on national imposed targets, where staff have to make rapid decisions about patients who have been in the emergency department approaching targets, or waiting in ambulances as the 45-minute target. And the reality is that staff are often pressured to meet these standards. And we recently looked at temporary care environments, for example, corridor care, as it's also known, and that pressure is a reality of everyday work. So safety and accessibility is something that's been considered and is known about by many people across the system as an issue. So where are we? And I guess the call here is that it's not HSSI. We're not the organisation that's going to come up with a magic answer about how we should be defining patient safety and how we should be defining quality. It's very much for networks and organisations to come together and decide why these things are important. And I was doing leading an investigation on safety management, and the focus was very much on ICB levels, and speaking to some of the patient safety specialists that work in ICBs over the last couple of years. What we've seen is that they've done their best to increase their capacity for safety, through learning how to use PSIF, but also understanding how to analyze things like LFPSE, and most importantly, coordinating cross-organizational investigations. So, for example, if there's multiple providers and there's a safety issue across a patient pathway, to sit there at ICB level and to be able to coordinate those different organizations and to ensure that the safety risks are better understood and mitigated against. The capacity for that sort of activity has been eroded to the point that in some ICBs it's now non-existent. So even though some ICBs are reporting maybe they'll do 4 or 5 complex cross-organizational investigations a year, that figure is now approaching 0. And many of these people, patient safety specialists working in ICBs, have new job role titles now. They're head of complaints instead of patient safety specialists. They're head of quality, or they're part of the quality improvement work. And there's real danger where that capacity that people have worked so hard in developing is now no longer being appreciated and understood, not just by the system, by the policymakers, people who write national strategies, but also by the trusts and the organizations themselves. It takes so much effort to get people bought into what safety is and how that can be integrated within quality improvement projects within a hospital. And that opportunity, that kind of ability to have people in those roles is so important for hospitals and for all providers within the healthcare system. And I think partially because of the way patient safety has been defined and largely misunderstood, that has now been eroded by recent policy changes. Hopefully, there's certainly some very competent and capable people out there that might shed some light on the future of patient safety and how it's integral to the work of healthcare. But it seems like the focus is a step backwards rather than a step forwards at the moment. So I'd have liked to have ended up on a positive point, and I hope to hear from maybe some of you that can say that that's not the case, and safety is working well in my provider, and I'm having no problems with resources. But and I, of course, would welcome that. But the reality is that the ability to demonstrate how safety is impacted on everyday decision making, and ensuring that healthcare is as safe as possible often hasn't been communicated. It might be communicated effectively by academics and by networks, but that message has not reached policymakers. Otherwise, they would not be making the decisions that they're making now. So that's what I was going to talk about, and I'm very happy now to take any questions, any clarifications, and thank you very much for listening.
Thank you very much, Jonathan. We've had two people that have had to go, but they commented on how much they'd enjoyed your presentation and that they will watch it afterwards on the video. But there's still a large number of us here, so can we first of all say thank you to Jonathan with a round of applause, which I know you won't be able to hear most people because they're on mute, but there's some claps for you. So much appreciated, I think, the talk there. Thank you. And do we have any questions from anybody? While we've got Jonathan with us, let's take the opportunity to ask some questions. I'll give people a chance to think about those, and if it's okay, I'll take chair's privilege by getting in there first. Do you think then, from your argument is strongly made for the distinction between quality and having safety as an underpinning foundation? I guess that other people might argue, though, that there are other underpinning foundations. You could potentially argue for any of those things as an underpinning foundation. And just thinking about the sentence that you highlighted, high quality care cannot be built on harm. I think you could also argue that high quality care cannot be built on inequality, for example, and there's a really strong argument that needs to be made around that. So I know you're kind of in essence promoting safety as that underpinning foundation, but how do you feel about then demoting other underpinning foundations that are really central to how we provide care safely and equitably in this country?
No, absolutely. I mean, inequalities is a really good example, and I think for me, people who are working in ensuring that groups of individuals who maybe aren't receiving the care that they need, I mean, they wouldn't describe what they're doing as safety work, I think, and some of that is the issue. I would say that that they are a safe system is definitely one that enables appropriate access and meets patient needs, and I think that should be part of a definition of what safety is. And I think that's that argument that if you look at that 2010 definition, it's all about adverse events, and it misses out those really important day-to-day activities that people are actually engaging in, especially looking at population groups which aren't receiving care. I mean, I think we would argue that that is a safety issue. That people a failure to access care means that the system isn't safe.
Thank you, Jonathan. Anybody else? Any other questions? So we have one here in the chat. I'm just going to open the chat up. Under PSURF, we're encouraged to understand how work is actually done. Do you think investigators should routinely explore the competing quality priorities such as efficiency, access and patient experience that shaped decisions rather than focusing primarily on the incident itself? Really good question there, Zainab.
Yeah, it's an excellent question, though. Thank you for that question. Absolutely. I mean, and that is, so it's easier when there's a target, such as a 4-hour target that looms ahead. But some of these decisions might and competing priorities might actually be hidden from a particular healthcare sector. So decisions that are made within departments might be more transparent and obvious how they might contribute to patient safety incidents, but there might be resourcing decisions that are happening all over a hospital trust, for example, which equally impact on. And actually, that bravery to point out that a contributory factor to an incident is because of a trade-off which has been made elsewhere for the best intentions. Often these trade-offs are made with the best intentions. New schemes, new ways of working. No one is doing it because they don't want to make things better. But they might be having downstream consequences. So understanding and being able to articulate those downstream consequences as part of PSIRF, I think, is really a valuable thing to do. So thank you. I think we've got a hand up.
Oh yes, we have. Sue Chong, can you do you have a question?
Hi, I work in maternity services, and we have a flurry of inquiries now to plow through. None of them sometimes feels like they've made particular impact. So I wondered what you thought about what the appropriate safety signal should be. So I don't think mortality is necessarily the best safety signal. So if you look at all 4 inquiries, they focused on maternity hospitals that don't necessarily have high rates of perinatal mortality or maternal mortality itself. So what do you think we should be measuring?
Absolutely. So there is going to be a new patient safety strategy, which is great. And I think for signals in maternity, have you heard of MOSS, which is the idea is like it's an early warning system for maternity, and it's not based on mortality, but it's based on other factors such as the number of people, a number of births that meet a certain category of incident, such as not enough oxygen on delivery and the consequences of that. Really to understand those patterns. I mean, the idea, I think the objective is to have more of a real-time identification of issues that might be happening. But I agree, safety signals are important, and any signal taken in isolation probably doesn't make a lot of sense. So it's about understanding that context, and that it ultimately is going back to workers done. Do you have a deep understanding of what the risks are that you're trying to mitigate within the service that you're managing, and is there capacity to even do that work? And when you're responding to things, to pressures, to recommendations that have been made elsewhere, is there enough time to reflect on your actual service and the risks that are present and can be identified by the people who are working in your particular area? And for me, that is what safety management is. It's about looking at the pressures that you're under, and not just responding to things which might well be important nationally, but there might be higher priority things in your particular service that needs addressing. So we can't keep chasing our tails. We have to be proactive in identifying risks, and absolutely having single measures won't help in that. The idea of leading and lagging indicators, the idea of being proactive is quite important. Thank you.
Did you have anything you wanted to say in response to that? I think MOSS is really not working, for example. So I'm going to be really contentious and say they've tried to adjust for potential complexity and whether or not the trust is an outlier based on specific measures and characteristics. However, for larger units such as mine, so I work at Birmingham Women's and Children's Hospital, we receive babies that are very ill, either, when the women give birth in our hospital or beyond that time frame. We are a surgical center, so babies with congenital anomalies will come to our unit, and we will flag because the babies may have very high needs, are very likely to be very high risk, and will trigger a warning. And we've had to comply with the reporting recommendations. I think Leicester have had a very similar experience. So I still don't think mortality itself is the best signal. They're still trying to measure mortality at the end of the day. And I wonder if other things that are softer markers, such as I think they've tried this, how satisfied your staff are, how many exit interviews have been completed and why staff are leaving in midwifery. Maybe some other measure of how effective the board are. So if you look at the initial Morecambe Bay inquiry, various organizations external to the Morecambe Bay Foundation Trust had insight about the ongoings, but they just weren't talking to each other. And so separate isolated incidents may come across as separate isolated incidents, but there was a lack of triangulation. The Nottingham inquiry, I think, reported on how long the piece of investigations took, and some took up to 2 years. So maybe a more appropriate measure is how many staff are trained in piece of investigations and what the output of those investigations are.
Absolutely. No, I mean,
I'm just throwing things out there.
No, absolutely. And I think I think it's an admirable thing that, what has been attempted, but clearly it's not going to work for all centres, especially if you have incredibly, very high acuity. It's a specialist centre, very, very ill patients. And absolutely, that wider understanding, the different measures, I think, that would be useful to hear about more of those measures if they're more sensitive and can capture and arguably, are they actually capturing the risks to a point that they're understood and we can develop risk controls to mitigate them? Because if they're not, then what are they telling you? Is it just about generating a league table, or is it about having a proper risk management system, which doesn't necessarily emerge magically from a set of metrics? So thanks for that. It's great. Thanks, Sue.
Thank you. And I think your points really fit with Jonathan's thesis that we need to think about a different definition, a broader definition of safety, in which signals would really come from staff, wouldn't they, and the patients that you're caring for, rather than necessarily the outcomes. So I think really important points there. Adam.
Thanks very much, Jonathan. Really, really interesting talk this afternoon. So I kind of want to think about concepts of harm. So I work on our children and young people's patient safety work stream. Children in the main, very fit, very healthy, not too many of them come into hospital, but many of them experience patient safety events. The difficulty we have is around how we measure harm. Mortality is kind of the main thing that we'll use, and that's a nice binary. It either did or it didn't happen, so I kind of see that. But we're increasingly interested in those socioeconomic determinants of health, which we know contributes a lot more to adverse events, adverse outcomes. But how do we go about within our systems defining those harms? Because it's not the biomedical model of harm. It's not the wrong arm was chopped off, the wrong organ was removed, and they were given the wrong dose of a drug and their LFTs went off slightly. We're talking about parents don't feel safe, so they lose a day of work because they feel they have to be in hospital. We've got an avoidable hospital admission that means days out of school. It's those harms for kids that probably add up more. And it's how do we start to shift our policymakers away from this notion of everybody leaves hospital and they're okay and they're smiling, to actually thinking about, well, actually in the longer term, what we do to them in our care actually makes their life outcomes worse. How do we start shifting that? Because I think that's my big challenge at the moment.
Yeah, it's really interesting, Adam. Thanks for those reflections. And of course, I agree that is the approach. And is to, we hear policy shifts towards community, for example, from hospital to community, and we hear about the need for preventative healthcare. But then we get national strategies which are just about NHS funded care. Mm-hmm. So it's not joined up. And when we're talking about, for example, quality management or safety management systems, they're being developed in places like maternity, or they're being developed in isolation. And I absolutely agree. It's that understanding, almost like a SEEPS 3.0 approach, where you have a patient who has multiple contacts with healthcare services, but also social care services, and understanding the determinants of the likelihood of whether those contacts are going to be meeting those patients' needs or not. And it's a complex model. It's a model that involves a non-isolated view, I think, of services. And so absolutely, any work that can kind of shed light to where you get that kind of, if you prioritize the service for a particular group of patients at a particular time in their pathway, and that's likely to have the most impact on their long-term health outcomes, then absolutely that's what we should be doing. And it's quite different from counting pressure ulcers.
Yeah, absolutely. Thank you very much.
Great question, Adam. Thank you. Anybody else? Alison, I think one's come up from Alison in the chat. Changes in patient safety role descriptors in ICBs is interesting, e.g. head of complaints, especially alongside the lack of adequate contemporary definitions of safety. How can we address these kinds of semantic issues with policymakers?
Yeah, I mean, I wish I knew. I mean, one thing that HSSIB, I can reflect on what we're doing. We've got a new strategy for building education, investigation excellence within healthcare, and part of that is to going out and supporting people, either trusts or in ICBs, to actually really be able to argue for these roles, because I think that there are instances where it is possible for people who have got, say, safety qualifications, they can demonstrate the impact that they're having, to build up a case for these roles. But absolutely, I don't know. There's some great people on boards within trusts who do get it, but the pressures are from the system, tell them to do something else. So absolutely, it's something that these networks really should help with. But it's very disheartening to hear that people who've been working for safety for 20 years, 30 years, have recently been trained, for example, by Loughborough to do the patient safety specialist course. Were making good progress, had 2 or 3 people in their team that they thought they were making good progress towards making a difference across their organization with regards to what safety is, and now that being eroded further is incredibly frustrating to hear. So absolutely, we don't have the answer to that, and it has to be a community effort, I think.
Thank you for the question, Alison, and the answer, Jonathan. We're going to let you go after one more question, Jonathan, because you're doing a lot of work there. So, last question is from Ruth. Over to you, Ruth.
Hi, John. Thanks so much for a great talk. I completely agree with a lot of what you've said, and I suppose now I'm just playing slight devil's advocate. So, apologies, particularly as it's apparently the last question. I suppose linking in with Alison's point. I wondered to what degree some of this is just almost rearranging the deck chairs, and it's something that we're very good at doing within the NHS. And so I suppose I wondered really whether you could see any unintended consequences of separating safety out from quality, from the other dimensions of quality, and what I suppose you hope would happen as a result of doing that. I think I'm asking this in the background of exactly what you've described, a system where actually people seem to be eroding kind of the focus on safety, where it's not professionalised, there's a lack of skill, time, space, etc. to do all of this, and whether in that context separating these things out might be could have unintended consequences, whether you discuss that as a group.
Yeah, I think separating them out without understanding how they link to the other dimensions, I think wouldn't be a good idea. But to have a definition of what safety is, I think would be a good starting point. That's more encompassing of the realities of the day-to-day work. I think getting together and really demonstrating what the value of safety is beyond a reduction in performance targets, I think is really important. And ultimately, there still isn't much work or idea about how much a safe system could avoid things like litigation and save billions of taxpayers' pounds in trying to mitigate against some of the highest risks that impact on the healthcare system. So it's until we have kind of like a framework that's able to demonstrate that how much safety is valued, but also that capacity that having people in the system who understand the methods, are able to confidently apply methods, to understand work as done, and to actually then go on and be involved in quality improvement projects that are sustainable. I mean, for me, that's what safety is, and maybe that more wider scope of safety activity isn't fully understood by policymakers. So that's why they make these decisions, I think, without fully understanding what it is. But thank you, Ruth.
Thanks, John.
Well, thank you so much on that note. And we've all been given a task, I think, to go away and come up with an argument for what is the value of safety, which if perhaps we presented better, we might have more of an individual focus on it. So thank you so much, John, for a really inspiring talk today. And thank you, everybody, for being here at this Safety Net seminar. See you next time. Bye.
Thank you, everyone.